Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about intrapartum care recommendations by WHO in 2018. Okay, this is an important lecture really for medical students, for obstetrician, and for midwife in every part of this world. Okay, so what we wanted to discuss in this lecture: the care throughout labor and birth. This is a general recommendation. Then the first stage of labor, second stage of labor, third stage of labor, care of the newborn, and the care of the woman after birth. As I said, this recommendation published by the WHO in 2018 and including an important items related to intrapartum care, hoping for positive childbirth, okay, and included updated definition and duration of the first and second stage of labor based on evidence from systematic reviews. And the recommendation presented in this guideline are neither country nor region specific and acknowledge the variation that exists globally as to the level of available health services within and between countries. As all of us know that the healthcare system differ between countries. So let us start with the general recommendation about care throughout labor and birth, which include respectful maternity care, effective communication, and companionship during labor and the continuity of care. What about respectful maternity care? You should respect your patient, you should encourage confidentiality and maintain the woman dignity, privacy. All of these are important during childbirth. Effective communication between maternity care providers and women in labor using simple and culturally acceptable methods. This is very important, and use simple words and the language can be understood by the woman. Okay, this is very important. What about companionship during labor? This is a choice of the woman during labor to choose her companion, maybe her mom, her husband, and so on. Okay, what about the continuity of care? Continuity of care should be started during pregnancy, really, during antenatal care by the midwife in healthcare system, giving the midwife opportunity to do care for pregnant lady and during labor also. And this midwife, either one or a small group of midwives, should be well known to the woman who is going to do birth. Okay, so this is very important general recommendation. Okay, let us start with the first stage of labor with the definition of latent and active first stage of labor, because there is some changes here differ than that in partogram. Okay, and the changes in this recommendation, which encourage the WHO to publish the labor care guide, which is replacing partogram in different areas all over the world right now. And I have a lecture about labor care guide and partogram. You can see the videos of my lectures on my channel. Okay, what about the definition of the first stage of labor? Latent, we all of us know that the first stage, which starts with true labor pain, okay, and the end with full dilated cervix, okay, and it is divided into latent phase and the active phase. Latent phase is the period in which there is painful uterine contraction and cervical effacement and some dilatation of the cervix up to 5 centimeters. So latent phase continue right now, updated definition, up to 5 centimeter, okay? And the active phase start after 5 centimeter with regular painful uterine contraction, causing more rapid cervical dilatation till reaching full dilated cervix, 10 centimeter, and also increasing the effacement of the cervix. Okay, so I have latent phase up to 5 centimeter. I have active phase from 5 centimeter to 10 centimeter. This is the new. The past definition was the latent phase up to 4 centimeter only. But nowadays, up to latent phase up to 5 centimeter. Okay? Okay. What about the duration of first stage of labor? Is it fixed or not? Is it variable? Okay. Latent phase is variable between women. So we cannot say certain hours for each woman. Okay? It is variable. The latent phase, as regard the latent phase. While the active phase, which start after 5 centimeter dilatation of the cervix, in primary gravida, doesn't extend beyond 12 hours. In multipara, doesn't extend beyond 10 hours. Okay? Okay. So, this is as regard the duration of the first stage of labor. We said latent phase and active phase, and we said latent phase is variable, while active phase, I said either 12 hours in primary or 10 hours in multipara. Okay, let us go to the next. Progress of the first stage of labor. As we know from previous partogram that at least cervical dilatation should be 1 centimeter per hour. And this is present in partogram as an alert line with 1 centimeter per hour dilatation of the cervix. However, it was found that women in latent phase, the cervical dilatation is variable. So it could be slowly than 1 centimeter per hour. Okay? As all of us during latent phase. But the acceleration of cervical dilatation starts from the active phase. Okay? A minimum cervical dilatation rate of 1 centimeter per hour throughout active first stage is unrealistically fast for some women and is therefore not recommended for identification of normal labor progression. A slower than 1 centimeter per hour cervical dilatation rate alone shouldn't be a routine indication for obstetric intervention. Okay? So, this means that they are nowadays using labor care guide recommended by the WHO, published in 2020, with no alert line. There is no more alert or action line. Okay? Why? Because they said in active stage of labor, some ladies, the cervix dilate less than 1 centimeter an hour and still giving birth outcome which is good and without complication. So there is variability between women in the rate of cervical dilatation. Labor may not naturally accelerate until cervical dilatation threshold of 5 cm is reached. Therefore, the use of medical intervention to accelerate labor and birth, like augmentation with oxytocin, before this threshold is not recommended. So don't interfere to hurry or accelerate labor in latent phase by augmentation with oxytocin or taking a decision like cesarean section, okay, because there is delay in progress. Okay, so you should wait till reaching the active phase, then do follow up for the progress of cervical dilatation and head descent. Okay, what about the labor ward admission policy. For healthy pregnant women presenting in spontaneous labor, a policy of delaying labor ward admission until active first stage is recommended only in the context of rigorous research. They are doing now many research or clinical trials. If we are admitting a woman in labor only in active phase in the first stage, or we can admit her earlier. Okay, some recommend to admit the lady so long as this is healthy pregnancy, no complication, no maternal or fetal complication or hazards. We can admit the lady during the active phase. Okay, however, this is a point under research. Okay, go to the next point, which is clinical pelvimetry. Should I do clinical pelvimetry routinely for all pregnant lady, healthy pregnant lady? No, it is not recommended. Why? Because they found that it increased the rate of cesarean section without improving the birth outcome. What about routine assessment of fetal well-being on labor admission? Should I put the patient on CTG, cardiotocography, to evaluate the fetal heart rate on admission? No, it's not recommended. But I can auscultate the fetal heart sound on admission using Pinard stethoscope or sonicate Doppler ultrasound for assessment of the fetal well-being. Okay? What about perineal or pubic hair shaving? Should I do it routinely? No, it is not recommended. However, it is depend on woman's will. If she wanna to be shaved before delivery, she can do it at any time by any person she prefer. For example, she can do it at home before going to the hospital and before start of labor. Okay? But as a routine, healthcare provider shouldn't ask the lady for that. It is not done as a routine. Okay, what about enema? Should we do enema for all women in labor? No, it is not recommended. It is invasive procedure and cause discomfort to the patient, and it is not allowed anymore. What about BV examination? Yes, on admission you should do digital vaginal examination, then at interval of 4 hours, so long as the patient is low risk. The pregnant woman is low risk, so healthy pregnancy, no complications, so I can do it every 4 hours. I can do it earlier if there is indication, whatever, maternal or fetal. Okay? What about continuous CTG or intermittent fetal heart rate auscultation during the progress of labor? I said on admission, I said it is not recommended to use CTG. What about during labor, the process of labor? Also, it is not recommended to do continuous CTG monitoring for healthy pregnancy. It is done only in high-risk pregnancy. But interrupted Pinard stethoscope or Doppler ultrasound auscultation of the fetal heart rate during labor is recommended. Okay? What about epidural analgesia for pain relief? Is it recommended? Yes, it is recommended for healthy pregnant women requesting pain relief during labor, according to her preference. Okay? What about opioid analgesia for pain relief? Yes, we can recommend the opioid analgesia like fentanyl, diamorphine, benzidine. Okay? What about other methods like relaxation techniques for pain management? Yes, including progressive muscle relaxation, breathing. You can ask her to take deep breath so the pain is reduced. or hearing music, mindfulness, and other techniques like acupuncture. Okay, so the patient can choose the method for pain relief so long as it is not harmful. What about the manual techniques for pain management? Like what manual technique? Like massage or application of warm packs. Is it recommended? Yes, it is recommended for healthy pregnant women requesting pain relief during labor. What about giving pain relief for preventing labor delay? Is it recommended? No, it is not recommended. Not give, not to give pain relief for the aim of preventing delay of labor or for reducing the use of augmentation in labor. This is, of course, not recommended. Oral fluids and foods. Is it allowed or not during labor? If the woman at low risk, you can allow oral fluid and food intake. Okay? What about maternal mobility and position? Should be bedridden or should be a mobile, can move? Yes, she can move freely so long as she is not high risk pregnancy. So adoption of mobility and upright position during labor in women at low risk is recommended. Okay? What about vaginal cleansing? Should I use antiseptic like chlorhexidine during labor for vaginal cleansing? No, it is not recommended. Okay? What about active management of labor? A package of care of active management of labor for prevention of delay in labor is not recommended. Is not recommended. Don't interfere in the latent phase at all. Okay. Routine amniotomy. The use of amniotomy alone for prevention of delay in labor is not recommended. What if I did early amniotomy and the oxytocin? Is it allowed to prevent delay labor? No, it is not allowed. So it is not recommended to do early amniotomy and the oxytocin infusion. What about oxytocin for women with epidural analgesia? Some may believe that we will use oxytocin for prevention of delay in labor in women receiving epidural analgesia. No, it is not recommended to do that. Don't give oxytocin for women with epidural analgesia aiming to prevent delay in labor. No, it is not recommended to do that. Giving antispasmodic agents for prevention of delay in labor is not recommended also. What about intravenous fluid to prevent labor delay? No, it is not recommended. Let us go to the second stage with the definition and the duration of the second stage of labor. As we know, second stage of labor starts from full dilatation of the cervix and the end with childbirth. Okay, and you can divide this second stage of labor into passive phase and expulsive phase. What is the difference? During expulsive phase, the patient feels the urge, involuntary urge to bear down. And women should be informed that the duration of second stage varies from one woman to another. If she is gravida, usually completed up to 3 hours. While in multipara, usually completed within 2 hours. What about the pulse position for women without epidural analgesia? For women without epidural analgesia, she can adopt birth position according to her choice. What are the positions? Either recumbent, semi-recumbent position with an angle with horizontal 45 degree or above or lower than that, or in sitting in bed position upright, or squatting position, or all four position, what's called the knee elbow position. Okay, so all these are positions for delivery. Okay, during the process of labor. Okay, okay, and the patient didn't take epidural analgesia. She has the right to choose the position, as I said, and there is no great difference between these positions as regard maternal and fetal outcome. Okay. However, some clinical trials said that the upright position associated with more perineal laceration and more postpartum hemorrhage, but the advantage of upright position, less instrumental delivery and rapid progress of labor and descent. Okay, of the head. Okay, let us speak about if the birth position while the patient taking epidural analgesia. Also, the adoption of birth position of the individual woman's choice, including upright position. You will say upright position while she already in epidural analgesia. I'll say we depend on, in many centers they are using low dose epidural analgesia, which can't block the motor nerves. But if high dose epidural analgesia will block the neuroaxial, okay, so the patient can't move. So this is, we are not going to do upright position in this situation, or the mobility of the patient should be, the patient should be bedridden, okay, if the motor nerves are blocked, neuroaxial block, with high dose epidural analgesia. But we are talking if she took low dose epidural analgesia, she can choose the position she wants. Okay, so it is recommended to give the patient the right to choose the position of labor. What about the method of pushing? Women in expulsive phase of the second stage of labor should be encouraged and supported to follow their own urge to push. So, healthcare provider should support her to push when she feels the desire or urge to push. Method of pushing for women with epidural analgesia. Okay, you will say the woman under analgesia now, right now, epidural analgesia, so the urge for pushing is not present because of epidural analgesia. She can regain it at any time. If she regain it, she will push, involuntary pushing also, okay? Or you can ask her to wait for 1 to 2 hours, then push, so long as the health care facilities is good and everything is available for evaluation of the fetus and the fetal well-being and evaluation of fetal hypoxia at any time. So you can delay the pushing 1 to 2 hours after full dilatation of the cells. Okay? Okay. So to be sure that you are in expulsive phase. What are the techniques for preventing perineal trauma? Is it recommended or not? Yes, it is recommended. What is these techniques? Like, for example, warm compresses in the perineum, guarding of the perineum, okay, massage to the perineum. All these are techniques for preventing perineal trauma. The original reaching maneuver is no more recommended, is not recommended, okay, but guarding of the perineum, warm compresses to the perineum, and the perineal massage is recommended. Episiotomy policy. Routine or liberal use of episiotomy is not recommended for women undergoing spontaneous vaginal birth. Okay? So it is done only when indicated. What about fundal pressure? Is it recommended? No, it is not recommended. What about the prophylactic uterotonics? Yes, it is recommended to give uterotonics for prevention of postpartum hemorrhage during second, third stage of labor, like oxytocin, 10 international unit, intravenous or intramuscular, is the best choice for prevention of postpartum hemorrhage. If it is not available, you can use methyl ergometrin or ergometrin, or combination of oxytocin and ergometrin, or use of misoprostol 600 microgram oral. Okay? What about delayed umbilical cord clamping? Delayed umbilical cord clamping is recommended for improved maternal and infant health and the nutrition outcome. This is very important. What is meant by delayed clamping? From 1 to 3 minutes. So not to be earlier than 1 minute. From 1 to 3 minutes. This is what is meant by delayed umbilical cord clamping. Some will say this may carry risk if the patient high risk for HIV and they can transmit the HIV to the baby. We can say no, the risk, if I didn't do test for the patient for HIV, or she has or her partner has HIV and I don't know if she carry HIV or not, also delayed umbilical cord clamping is recommended. Why I say that? Because the possibility of transmission because of delayed clamping is very, very low. There is other risks from transmission during a pregnancy, vertical transmission, during birth, during vaginal birth, through the secretion and the blood, and after delivery from breastfeeding. So there is other risks, not the delayed clamping, which will cause the transmission. Also, the recommendation say that delayed umbilical cord clamping is recommended even if her partner carry HIV or I didn't test her before delivery for HIV. Okay? What about third stage of labor controlled cord traction? Is it needed or recommended? Yes, it is recommended so long as the person attending, the healthcare provider attending the labor or giving care during labor has a skill to do controlled cord traction. It's also called the branded Andrews method. Gentle downward cord traction while by one hand, while the other hand do pushing to the uterus up. So it is counter traction, and it is done only during uterine contraction to avoid inversion of the uterus. So it should be done during uterine contraction. Okay? Why it is done? To facilitate the delivery of the placenta, to decrease the postpartum hemorrhage to shorten the duration of third stage, to decrease blood loss. Okay, this is the aim for controlled cord traction. What about, so we said now in third stage, yes, active management of third stage using oxytocin, intravenous or intramuscular, or alternatives with Routonics. Also controlled cord traction, yes, is recommended. Uterine massage, is it recommended or not? Sustained uterine massage is not recommended as an intervention to prevent postpartum hemorrhage in women who have received prophylactic oxytocin. So sustained uterine massage is no more recommended. What about care of the newborn? Should I do routine nasal or oral suction after delivery while the pregnancy was low risk and the amniotic fluid was clear and everything was fine? No, it is not recommended to do routine nasal or oral suction for the baby. Okay? Of course, if the baby starts breathing and everything is fine, no need for routine nasal or oral suction. What about skin-to-skin contact between the baby and the mother? Newborn without complication should be kept in skin-to-skin contact for the first hour after birth to prevent hypothermia and to promote breastfeeding. Okay? This is recommended for 1 hour in the first hour. What about breastfeeding? All newborn, including low birth weight babies who are able to breastfeed, should be put on to the breast as soon as possible after birth when they are clinically stable and the mother and the baby are ready. Okay? So encourage the early breastfeeding. What about hemorrhagic disease prophylaxis using vitamin K injection intramuscular for the newborn? Yes, it is recommended to give 1 milligram of vitamin K intramuscular after the first hour after finishing the skin-to-skin contact with the mother. Give the baby 1 milligram intramuscular vitamin K. What about bathing of the baby and the other immediate postnatal care of the newborn? Bathing should be delayed until 24 hours. Okay? But in certain countries, for cultural reason, they wanna toward the baby earlier. So you can do it, but at least after 6 hours after birth. After 6 hours after birth. So the recommendation is 24 hours. But for cultural reason, in certain countries, the family wanna to bath the baby, so at least 6 hours should pass after delivery to do bathing. Okay? Okay. What about clothing? Appropriate clothing of the baby. Ambient temperature is recommended. Okay? What does it mean? 1 to 2 layers of clothes more than adults. And use caps also for the baby. Okay? And the mother and the baby shouldn't be separated and should stay in the same room 24 hours a day. What about the tone of the uterus assessment? Uterine tonus assessment. Yes, is important and recommended to do uterine tonus assessment for early identification of uterine atony. Okay? So, sustained massage is not recommended, but test for uterine tone, is it contracted or not? Yes, is recommended. You can find the difference. Routine massage to the uterus postpartum, sustained one, is not recommended. But evaluation of uterine tone, if the uterus is contracted or not, is recommended. Antibiotic for uncomplicated vaginal birth, is it recommended or not? Not recommended. So long as it is uncomplicated vaginal birth, it is not recommended to avoid antimicrobial resistance with increase in use of antibiotics. What about routine antibiotic prophylaxis for episiotomy? It is not recommended also, so long as it is not complicated by infection. Okay? The same for first and the second degree perineal tear. But in third and fourth degree perineal tear, you should give antibiotics. Okay? So, first and second degree perineal tear, simulating episiotomy. Not recommended to use prophylactic antibiotics so long as it is not complicated. Okay? But third and fourth degree perineal tear should receive antibiotics. What about routine postpartum maternal assessment? All women should have regular assessment for what? For vaginal bleeding, uterine contraction, by testing the uterine tone, as I said before, fundal height, okay, temperature and the heart rate, routinely during the first 24 hours, starting from the first hour after birth. Also, you should measure the blood pressure shortly after birth. If normal, the second blood pressure measurement should be taken within 6 hours. What about urine output? Urine void should be documented within 6 hours. So I measure the blood pressure after birth, then after 6 hours, I'll measure the amount of urine within 6 hours. Okay? I'll do evaluation for uterine tube, vaginal bleeding, fundal height, temperature, and the heart rate during the first 24 hours. Okay? Starting from the first hour, immediately from the first hour after birth. Okay. What about postnatal discharge following uncomplicated vaginal birth? When to discharge? After 24 hours after birth. In cases uncomplicated. Okay? If uncomplicated vaginal birth in a healthcare facility, healthy mother and the newborn should receive care in the facility for at least 24 hours after birth. This is the last slide. Thank you. I recommend my textbook of obstetrics containing this lecture and also lectures about the partogram and labor care guide. I recommend to read all 3 lectures in this textbook of obstetrics. Also, it is available in YouTube channel. All these lectures related to each other. So I recommend this lecture today and partogram and the labor care guide. These 3 lectures is important. And post textbook of obstetrics and gynecology available on Amazon belongs to me. I hope it will be beneficial for you. Thank you. I'm Dr. Ala Misbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.